We'd like to thank the GIE Journal for their invitation to talk about our recent article in the journal, Endoscopic Gastroplasty versus Laparoscopic Sleeve Gastrectomy, a non-inferiority propensity score match comparative study. We know endoscopic gastroplasty has gained significant attention and popularity in the obesity treatment paradigm. And there are questions that have been answered already about the techniques, how safe, how effective, especially in the first 2 years. And previously we published in 2019 a lot about management of these patients, preoperative, intraoperative, postoperative, weight loss, the technique itself. Is it reversible, not reversible? Can you convert it to other techniques like laparoscopic sleeve gastrectomy? So there are a lot of questions that answer. But with this popularity, with this prevalence that's increasing significantly and utilization in the bariatric medicine and bariatric surgery and with endobariatric, there are some other questions that we need to answer. How do we compare it to the most important and the most commonly performed procedure nowadays, which is laparoscopic sleeve gastrectomy? We are not saying it will replace laparoscopic gastrectomy, but we are saying this is the index procedure. How does it compare to it? So what we did, we gathered 3,018 patients in each arm, laparoscopic sleeve gastrectomy and endoscopic gastroplasty, ESG and LSG. And then we see, and most importantly, their weight, how does it compare, comorbidity resolution, and the safety. The non-inferiority, we chosen 10% total weight loss. So if ESG is within the difference between ESG and LSG within 10% from the weight loss of LSG, then we call it non-inferior. So the difference between them within 10%, we call it non-inferior. If the difference is more than 10%, we call it inferior. And the majority, the average weight loss in ESG patient compared to LSG was within 10% of those with LSG, which means it's not inferior according to the design of the study. With regard to comorbidity resolution, diabetes was or achieved resolution in 64% in ESG compared to 82% in LSG. In dyslipidemia, 64 in ESG and 66 in ESG and 64 in LSG, almost the same. Hypertension, which is very important finding, and also we observed this in the previous study, that if you intervene early, especially in hypertension, you will be able to reverse the disease better. And this is, I think, in almost all bariatric intervention. When you have somebody with comorbidities, if you intervene early, even pediatric or adult, same thing. You'll intervene early, you'll reverse early. With regard to the safety margin, they are almost showing a very safe margin, and they are no different in terms of safety and outcome related to adverse events. The good things also about ESG that you can reverse it, you can remove the sutures completely and the stomach will go back almost to normal, and you can do it early or you can do it late. Second, also you can convert it to laparoscopic sleeve gastrectomy, because some patient will come to you and say, well, now I'm supposed to lose, for example, because there are patients who will come to you with BMI 40, and then they lose maybe 20 kilogram, 52 kilogram, and they'll say, oh, I'm not happy. Again, you can reverse it, or they regain their weight, or they did not lose as much as they want. You can convert it to bariatric procedure. You can redo the procedures. Some patient might have the sutures not functional anymore, or they did not lose much, or they are get loose stomach. You can do it again. So these are important then. That's reversible. You can do it to another procedure. You can convert it. There is no problem with that. We will come to the take-home message here. Now, we know now it's effective. We know it results in weight loss. Durability, we know up to 3 years, and now there are some 5 years, but we don't know after that. But then, how do I offer it to my patient in the clinic? at what stage and what criteria and what BMI and what weight loss expected. And how do I compare it? So now you understand you can make it 10% from LSG as weight loss. We prefer it to be offered for those who are 27.5 BMI overweight to 35 BMI. In that range, it is, I think, one of the best solutions nowadays available in our hand. Above 35, bariatric surgery is more effective, we know that, and durable. Below 35, between 30 and 35, if you have diabetes and hypertension and other, still bariatric surgery is a very good option, but ESG is also an alternative. Some people will not like to go for bariatric procedure. They would like to go for endoscopic or endobariatric procedure. So I think that's an excellent intervention. So in summary, endobariatric is safe, effective. It will result almost, its weight loss is within 10% of LSG, laparoscopic sleeve gastrectomy weight loss, and it is safe and durable for up to 3 years, and hopefully it will continue after that. Thank you again for the journal and for you for watching.